The record. Welcome to this Friday afternoon to our AIHM Wellness Webinar. I'm Tabitha Parker, and I'm the Executive Director of the Academy of Integrative Health and Medicine, and we are just so pleased to have with us today Homero del Pino. He is here from Charles Drew University, and he'll be leading us through an interactive forum on medical ethics in underserved communities. And for those of you coming to us for the first time, the Academy of Integrative Health and Medicine is a global interprofessional integrative health association working to transform healthcare, body, mind, spirit, community, and planet. And we've been around since 1978. So I just really want to welcome our guest speaker today. Homero del Pino has a BA in philosophy from Cornell University and holds a doctorate in philosophy and a Master of Science in clinical research from UCLA. He's an associate professor in the Department of Psychiatry and Human Behavior at Charles R. Drew University of Medicine and Science, and an adjunct associate professor in the Department of Psychiatry and Biobehavioral Sciences at the David Geffen School of Medicine at UCLA. He's the principal investigator of Entre Hermanos, an NIH-funded randomized controlled trial to test the efficacy of engaging the siblings of Latino men who have sex with men in the development and dissemination of HIV PrEP promotion messages. And he is the recipient of a KO1 Career Development Award to explore strategies for engaging the families of Latino MSM in HIV prevention efforts. So Homero, we are just so pleased to have you with us today, joining our community. And I just really want to welcome you on behalf of the BIPOC committee who really put this together. And we're just really so thankful to have you. So welcome.
Yeah, thank you. I'm very excited to be here. Let me share my screen. All right. Okay, so thank you, everyone. Well, thank you all for inviting me here. I'm happy to talk about medical ethics in underserved communities. I would like to acknowledge Dr. Jean Davis for reaching out to me in the first place to come here, and Dr. Tabitha Parker and Dr. Yvette Miller for giving me some case studies to prepare for this. As you saw from my intro, I am not a doctor, not an MD. So these cases I found to be very interesting. I'm probably doing something very different with the cases than what you all may have anticipated. So just bear with me. So the goal for today is to engage in a critical examination of moral reasoning in challenging cases. So it's not just looking at the cases. What I'd like to do is actually go underneath and let's examine, how do we think about these cases in the first place, right? Because there's kind of an assumption, the starting point, that we kind of know what we're doing, and now it's a matter of figuring out these hard cases, right? So I want to kind of look at that first and see sort of what assumptions that we bring to the table, but moral assumptions that we bring to the table when we are when we face challenging cases. So the objective is, hopefully by the end of this talk, all participants will be able to think critically about ethical theories and that underpin common moral reasoning and identify some limitations of ethical cultural relativism. So I do want to go through some cases, and I want to end with a sort of a mini talk on ethical cultural relativism, which is something that something that gets under my skin, and I think it's important for everyone to talk about, especially when we talk about ethics. So again, my talk will be divided into two parts. We'll look at some morally challenging cases and the ethical implications of these cases, and also look at what is this idea of ethical cultural relativism. So let's start with the challenging cases and ethical implications. And just by the way, for folks who may not be aware, if you see me looking over to the side, I have two screens. I have my presenter view, so I can kind of look at my notes. I am not being distracted by other things. And I do have a dog and unruly teenagers, which might feature in the background, background music for my talk. All right, so let's look at the first case study. I changed this around a little bit from what was given to you to COVID-19 and ventilators. So this was the first case, an African-American woman, 74 years old, in good health. She's a retired attorney. She comes in with a fever of 101 degrees. She's been coughing for the past 24 hours, or her cough started 24 hours ago. She reports shortness of breath, chest congestion, general body aches. Oxygen saturation is in the upper 90s. And she's feeling worse with more labored breathing while she's been waiting in the ER. Key feature, you might think. She reports that her neighbor has COVID-19, but she doesn't recall being in contact with the neighbor. At the same time, we have a younger Asian woman who comes also to the ER. She's a manager of a retail store. She's been ill for 2 days. Today, she has a fever of 103.5. She has a wheezing cough, also labored breathing. Her oxygen saturation is in the low 90s. She has type 1 diabetes that's not under control. She is overweight. And she attended an indoor wedding with over 50 guests 10 days ago. The problem, you have one ventilator. You have one ventilator left. So what is a reasonable course of action? A, provide the ventilator to the older adult. B, provide the ventilator to the younger adult. Or C, both patients are equally entitled to the ventilator, so just flip a coin and leave it to chance. And this is where everyone can jump in.
So feel free to just unmute and if you'd like to add anything, add to the discussion, since this is an open forum today, we really just invite you all to participate.
And I also invite you all to show yourselves on video. It makes the conversation a little easier than talking into a void.
So, so thank you. I love the way that you did this. So, so I'm Yvette Miller, and I'm a physician, and I'm African American. You can see me talking. So, I mean, so the dilemma here, well, things that we consider when we're determining sort of who gets, when there's limited resources, who gets the resources. Is, we think about, what the current health status is of the individual, in terms of, needing ventilator support versus the use of convalescent plasma. So what we have come to know about convalescent plasma over the last 6 to 8 months is that initially we thought once a person was on the ventilator was the time to give it. But now we understand that we want to prevent people from getting worse. So the earlier you give convalescent plasma in the course of a condition, the better the likelihood it will be that that person will recover. And so the things to consider here is, and things that might bring bias into the situation is, one, or a few things. One of the patients is older, but it's in good health and doesn't have any evidence to her knowledge about the exposure. But then we have an individual who has some chronic medical conditions, and we know that people who acquire COVID are susceptible based on their those chronic conditions. And this person had what could be a defined exposure by being at this large gathering. So those are all things that come into people's minds to make a decision about who gets these resources. The ventilator is a limited resource, and convalescent plasma is a limited resource as well. So they're both limited resources. Who gets what? So I'm not going to answer the question, but those are the things that we consider as clinicians as to how we divide up some of the things that we consider and think about when we're talking about the distribution of limited resources.
All right, so if we were in person, we would have a little flip chart where I would kind of write up a bit of what you said. If I remember it all, you talked about, I believe you mentioned age, underlying health conditions, and sorry, what was the last thing you said? You talked about
Limited
age,
resources,
health conditions,
and limited resources. Mhm.
Okay, so
And
who gets
Erica is
ventilated?
saying in the chat too, is the younger patient on insulin? If yes, for how many years is another question that came up in the chat, just to share.
Okay, again, I'm not an MD, but I would want to know why would that be relevant?
That would actually determine the level of diabetes that the patient had.
That's right. And I was going to put that, this is my scenario, sneak preview, this is my scenario. And I started to put something in there about insulin, but I did leave that out.
Okay, so let's suppose they have not been using insulin.
Well,
Or been
instead
not
of
good
putting the
about it.
information, instead of putting the information in about insulin, that's why I put the piece in there about the person not being, you know, under well control. Because you would assume that if a person in general, people who are under the, you know, are under best control are ones who are following their treatment regimen, you know, and if it involved insulin, they would be taking it appropriately. So that's why I mentioned the symptom and not the treatment, not being in control.
Okay.
Treatment.
And also
see.
someone may want to take into consideration the fact that this person actually exposed herself. You know, the regulations state that you should not be in a crowd less greater than 10 people. And she decided to go to a wedding with more than 50 people. So the question is, how do you feel about a person who's not taking on the responsibility of being exposed to COVID based upon a woman who said she doesn't recall being around her neighbor in comparison to the person who just knew what she was doing and just did it?
And had a chronic medical condition and knew that she was susceptible. So all
Absolutely.
these things come into play, yes.
Right, so I think that's the, I think for us as providers, I think that's, it's hard to not, it's hard to get away from looking at the person, what responsibility does a person bear in their own, in the situation that they find themselves in, right? And when I was looking, when I thought about the same thing, I did a similar talk recently, and I actually used an example of a anti-masker activist, 30 years old, you know, who gets COVID, versus, you know, well, not versus, but, you know, a woman who's 45 with kids who's been compliant, you know, with public health regulations and protocols. And what I thought of at that moment was, what about smokers? Right? Like when we think about smokers, you are like, it's your fault that you got sick, blah, 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 right? And we've kind of moved away from thinking about, you know, blaming smokers or blaming people with addictions, right? And trying to understand like a greater context of how they make their decisions, right? And I'm wondering like, how easy would it be for us to do the same here when there are people who may be getting the wrong information about masks, or, you know, I mean, there's a whole movement against it, right? There are entire states that think that this is nuts, right? And then I think you have some really well-intentioned, good, you know, well-intentioned people who are being misled and misinformed. So all that factors into play. But so just to recap, we're looking at age, we're looking at health conditions, we're looking at their behaviors, right? Like what public health protocols are at play. Anything else we think we should consider?
Hi, this is Scarlett Soriano. And I think that this is an amazing case that brings up a lot of things. I agree, Homero, with the fact that it gets very messy, very difficult to get into a situation of sort of pinpointing, sort of focusing on a person's actions. And I think we can get into lots of gray scales. I wonder about a few things. I would want to know what is their hemodynamic state, right? Who is most likely to need this ventilator in order to survive at this time? We don't have enough information. We don't know, you know, I would want to know how stable is their blood pressure? How stable is their oxygenation? Are they going down into the 80s? Just came in the 90s, but who clinically is going to need this in order to sustain life? And I think that training ourselves to think about who's at higher risk as well. And so looking at the data that will support a decision that's going to sustain life, and then thinking about the larger network of resources, who can be safely transferred. I practiced rural medicine for a number of years, and routinely, when our resources were not capable of supporting life, we needed to transfer, and sort of having those thoughts early on so that we are able to then to be able to get people to the care that they need and triaging quickly. Those are some additional thoughts.
I'm just warning, we just need to watch our time because we want to run through the other cases too. So
oh, wow.
Who's the timekeeper?
We started a little behind, so
who's timekeeper? I don't want to take up all the time on this case.
Yeah, so I'll just say one. So you just finished mentioning clinical considerations, and someone in the chat mentioned other considerations, like what if the person has like social background, like if they have young children, for example, you know. So this is all fine and dandy, not to be flippant about it, but we'll come back to this. I think everything that people have mentioned, I think is important, right? But also notice no one actually made a decision, right? Everything we need to think about, but no one's made a decision. So what have other places done? So in New York, when they were being overwhelmed, this is back in April, you know, they talked about the right to withhold care from patients who are not likely to recover. Doctors were worried about being sued. They were looking for guidance from their medical chief. Medical chief was looking for guidance from, you know, the governor. And it was, you know, like, what do we do if we don't have enough resources? In Alabama, they said persons with severe mental retardation may be poor candidates for ventilator support. And I'm missing close quotes there, but, you know, their language. You know, again, who gets these resources? And in Washington State, again, a sort of more clinical approach, you know, consideration of baseline functional status for each patient, you know, like declines in energy level, physical ability, and cognition, things to consider to determine who would get a ventilator. In Italy, they were a little more straightforward. Younger, healthier people were just given priority over older, sicker people, period. You know, end of story. Fortunately here, the federal civil rights officials announced that they will not allow hospitals to discriminate on the basis of disabilities, race, age, or religion. So, you know, Alabama couldn't quite, should not be implementing, you know, that the guidelines that they had. And just because we are living in a time of COVID, you know, as of yesterday, there were about over 187,000 new cases, and over 80,000 people are now hospitalized. Last month, there was a hospital in Idaho that reported being at 99% capacity, and they were already sending people to Portland and to Seattle. They were like getting people out because they did not have enough space anymore. And, you know, 1,962 people, sorry, today died. Sorry, that's a typo. They have died today. So I was gonna ask, like, what moral principles should guide the decision whether to give the ventilator to the 74-year-old African-American woman who's compliant, or the 25-year-old Asian woman who flouted public health protocols? So there was a study done looking at how should we decide, right? Sorry, let me go back. How should we decide? And this was a pilot study conducted in Baltimore, and they wanted to test the deliberative process. This was a community-based study between doctors and community members. They wanted to test whether the deliberative democratic methods could be used to promote an engaged discussion about complex ethical challenges. And they also wanted to develop specific deliberative democratic procedures that can be used in a statewide process if that were ever necessary, right? And this was a few years ago that they did this. So what principles did they come up with? So they came up with this idea of first come, first served. Patients are given ventilators in the order in which they are diagnosed until no ventilators remain. a lottery. Patients are assigned a number. Healthcare providers select a random number and give the ventilator to the patient with that number. Prioritize those most likely to survive. Again, people with the best chances of surviving. They were considering a flu pandemic. They were going to be given priority. Prioritize those with the most years left. Life cycle or fair innings. People have lived through the fewest stages of life. And what value do they have to others in the pandemic, right? So like first responders, clinicians, vaccine workers would be given priority. These are sort of the moral principles that they decided to look at. But if you think about these moral principles for a second, and we'll come back to them, they deviate a bit, if you will, from clinical guidelines, right? This is from UC, allocation of scarce critical resources under crisis standards of care. And again, their goal here was to look at medically relevant prognostic factors, for surviving acute critical illness, right? This is not talking about first come, first served, right? Maybe the first person who showed up is the least likely to survive, so first come, first served don't work. Doesn't give us much guidance from a clinical perspective. So again, all these principles, not clinically relevant. But what I want to point out, actually, and this is part of the discussion that applies even for the other cases moving forward, is, sorry, we skipped the, oh, sorry, I was on the right slide. The problem with some of these moral principles that we look to, whether we're thinking clinically, whether we're thinking other social issues, background considerations, are these principles really objective? Right? How objective are these moral principles? So let's think a little bit. Let's think them through. So first come, first served. That seems pretty straightforward, but actually it might perpetuate disparities. People who are closer to hospitals will always be the first ones to get there, right? And if you think about the rural-urban divide, right, people in rural areas are going to be, left out, basically, right? If we think about the history in LA, when South LA had few medical centers, and we go back to the founding of Drew itself, right, where there were no hospitals and not enough medical attention, African Americans would always be the last to arrive, so they would be the last served. So even when we look at a principle that seems on its face unbiased and objective, if we push on it a little more, we realize, maybe it's not all that biased it's not all that objective, right? And who's benefiting from this so-called objective principle, and how did this perpetuate disparities? I'm gonna skip over lottery, prioritizing those who are most likely to survive. I know we mentioned earlier something about looking at underlying health conditions. Oh, we know our communities are overburdened with medical conditions such as diabetes, heart disease, high blood pressure, right? So we're already starting at a disadvantage. So if we show up at a hospital and a doctor in good faith decides, well, I'm gonna go by these principles that are these objective moral principles, what's gonna happen? We're gonna get left out again, right? Prioritizing those with the most years left is ageist, period. Right? And value to others in a pandemic. If we have one ventilator left and we have to give it to a doctor or or any of the other patients we just saw, the African-American woman or the Asian woman, and we have a doctor, like who do we give it to, the last ventilator? Folks might think, well, an objective way to make that decision is to give it to the doctor, right? To someone who has value to others in a pandemic. But this idea of value, gets very slippery, right? I know when we were talking about vaccines, I saw people talking about give it to doctors first and first responders, and other people thought, no, find the most vulnerable first and give it to them so they stop coming to the hospital and stop getting infected and coming into the hospital. And value to others? What about a social influencer who might, move opinions, right? Would they get the ventilator over, say, a philosopher, like me? Philosophers, end of the line, social influencers, to the front of the line. So I only bring this up, not just because this applies to the COVID case that we're looking at, but even as we start looking at other cases, every time we think that we might be looking at objective moral principles, how objective are they really?
Could you get a
Right?
background?
No.
Just press your screen.
Motion bubble stop.
And might they be perpetuating the very disparities that we're trying to address? All right, let's move on. Again, what moral principles should guide the decision to whom to give the ventilator, right? And it's not clear whether it was the community comes up with these principles, or we rely on clinical judgments. This is hard. So the reason why I bring this up is because there are limitations to these moral guidelines. There is no unified moral theory, right? We talk about medical ethics, but it's not clear that there's a unified moral theory. There's a lot more we can say about these things, and they just kind of seem like an ad hoc combination of moral principles, right? That we use, and we give these guidance to health providers to then go on and make a decision about to whom to give a ventilator. And so these are limitations. Okay, second case. So any questions or comments before we move on to the second case? Okay, give me a sec. This is a transgender person, a female to male, 24 years old. History of intermittent pelvic pain for 4 months, increasing in frequency and severity. Person's medical history has no information under gender or sexual orientation. This is the third time the patient has presented to your facility. Okay, tenderness upon palpation of the lower abdominal region, increased tenderness in the left adnexal with a palpable mass. The vaginal examination was significant for profuse discharge. There was also pus-like rectal discharge. And the lab results were significant for increased white blood cells. Vaginal, anal, and throat culture are positive for gonorrhea. And the pelvic ultrasound was significant for left ovarian cyst and inflammation of bilateral fallopian tubes. So this person has a lot. When I was reading through this case, one of the first things that came to mind was, how did this get so far, right? And third time that the person's at your facility. So what is the reasonable course of action? A, to treat for gonorrhea and treatment of partners. Do A and also report the absence of adequate care to the medical director. Do A and discuss the case to providers who saw the patient prior to your intervention. Or D, do A and present a case during the monthly provider meeting. I am not giving an answer.
Hi, this is Rachel Abrams. I'm a family practice doc, integrative medicine doc. And I found this case so disturbing because it's hard for me to understand the incredible just lack of interested care that this person got. Mm-hmm. So it seems like an education of the entire team is in order. Not obviously treating, but in addition, I think you have to talk with the people who saw the person before, because if you're not asking a person about their gender orientation, how can you adequately take care of them? To me, that seems like a really important part of any of this. And also just a complete miss from a provider point of view. So it seems like whatever education is necessary, certainly, I think all these people need to be talked to, or maybe that's what happens during the monthly provider meeting. It actually needs to be presented so that everybody gets an education about how to be with transgender patients in the most basic way, as well as other specific concerns of transgender patients.
Yeah, and today is actually Transgender Day of Remembrance. And that's why I wrote this, because I knew the date we were going to have it. And we say that, but as an HIV specialist, I can be perfectly honest with you. I have had a number of transgender patients, and they come in with problems, and I check them below the waist, and they tell me, well, you're the only person that's ever done that. There are a lot of providers, regardless of the specialty, that don't want to take it to that level of actually seeing what's going on. They just listen and write down things. And if you notice, when I wrote the case study, I didn't say he or she. I just kept saying the patient. And that's something that's really important in dealing with transgender population, to understand, number one, that it's a spectrum, and to understand, number two, that that person decides how they want to be addressed. If they want to be addressed as Miss, Mrs., or male or female. And that's something that as providers, we need to be more in tune with rather than not. And I've seen this case before. It's an actual case. And I've seen the case with other sexually transmitted diseases like herpes. No one's ever looked at the area, see how bad the herpes were. All they said, well, you have herpes, so let's put you on some medication and let it go. So I think, I'm not going to tell you what I think the answer is because I wrote it, but it's really important that as providers, we look at patients as individuals, not as just a group of patients that happen to come in, and just assume that every TG is the same, be it a male to female or female to male. Every one of them is going to be different, and they're going to present differently.
And it's this kind of is lack of treatment, lack of adequate treatment that transgender individuals get when they do step out and into the healthcare system, that prevents them from coming into the medical care system. And things that they know, I should be taking care of this, but I'm just going to try to deal with it myself because I don't want to go into the healthcare system and be treated disrespectfully.
Very true. Do we have any conversations from our participants? Any recommendations or feelings? Can you read what's in the what's coming up, Jess?
Check
the chat.
It said, since the sexual orientation was not listed, maybe start by asking the individual their pronoun. Then we can address how this patient has been seen 3 times, yet has received no treatment.
And also the thing with gender and sexual orientation, they're 2 different things. And a lot of providers don't understand that. If I am a male to female, they assume that because I now present myself as a female, that I'm having sex with men. And that's not necessarily true. I may want to have sex with women. I may be bisexual. So the gender and the sexual orientation are 2 different things. And that's why I added on there the fact that the patient had anal gonorrhea too. And also remembering that just because you're a male versus a female doesn't mean that you don't have anal sex. And someone just said the answer is C.
And there are many transgender men who remain fertile and they can get pregnant as well. So that's things that people don't consider and even think about when dealing with the transgender population, is looking at them holistically, completely from top, literally, figuratively from top to bottom, to find out what their health status is. Yes.
And a lot of male to female have died of prostate cancer, and a lot of female to males have died of ovarian cancer because they're not looked at as who they were when they came in, when they were born. So they don't look at the ovaries, they don't look at the prostate, they don't look at a lot of things because of how they're presenting, because they're transgender.
So I didn't realize that it was National Transgender Remembrance Day. So, but luckily, let's look at some of the issues that transgender individuals face. They are one of the most at-risk populations. There are approximately 1.7 million trans people in the United States. They face hardships and have poorer health outcomes. 39% report earning less than $30,000 per year per household. More likely than the general population to face discrimination in education, employment, abuse by the police, harassment in public spaces, and assault. I'll get back to that in a bit. And of course, nearly all these issues are worse for trans people of color. It's the intersection, right? Race, gender, gender identity, sexual orientation, which will always make this even worse. So here are some figures on transgender and some of the social challenges faced by transgender people. I just want to focus on a few. I don't want to go through all of this. Again, almost 80% of them were harassed in school, while they were still in school. Over half have been harassed in public spaces like hotels and restaurants, including government agencies. And, about a quarter of them have lost their job because of their gender identity, right? This brings it back to people making less than $30,000 a year per household, right? And they are harassed by the police, right? Something we may not necessarily think about when we think about transgender or transgender person. One of 5 transgender adults is uninsured. Many cannot afford medical care. So 48 have postponed care when they were sick or injured. 50% avoided, preventive care. So because of these experiences, many hide their gender identities from health providers. Again, fear of retaliation, fear of harassment from their providers. Only 40% report being out to all of their providers, less than half. 28% report experiencing verbal harassment in the medical setting, and 19% have been refused medical care by providers because of their gender identity. So it's not only bad enough to be harassed when you're in a medical setting, but to actually be refused. So you go through the harassment and then still get refused anyway. And so then it's no surprise when people report avoiding care altogether because of stigmatization and harassment. And the challenge doesn't end there. So getting through the door is a problem. What happens when you get to the other side? Well, those who do make it to the doctors and disclose their gender identity, they still find themselves having to teach the medical providers, right? So there's a burden of having to teach the medical providers about themselves, about their needs, and what will be appropriate for them. So again, this is a problem, right? When people veil their identities in medical settings, their providers miss important information that should inform screening, diagnosis, and care. If we think back about the case that we were just looking at. But it gets even worse. If you were not aware, there's been a policy change this administration did with the Affordable Care Act. In 2016, Section 1557 of the Affordable Care Act, which prohibits discrimination based on race, color, national origin, sex, age, or disability, was extended to cover gender identity. But this administration, in all their wisdom, rewrote Section 1557 and took out gender identity. So they went back to pre-2016. And the US Department of Health and Human Services, their Office of Civil Rights, they expect that half of the 137,000 covered entities, hospitals, insurers, Medicaid agencies, community health centers, they expect half of them to rescind these protections through changes in policies and procedures. So they're already anticipating that this is going to happen. So we went from extending anti-discrimination protection for gender identity to taking it back. And this is going to impact at least half of these entities that are covered, by this law. So if it was bad enough at the individual level, now we look at a policy level, right? Like what's happening at a policy level, right? at a policy level, we are setting them up for failure when it comes to their health outcomes. But what interested me, or what jumped out at me, sorry, hold on, I gotta chat. What can we do to advocate? We'll come back to that. So one of the things that jumped out at me when I was reading this case that I think is relevant to ethics, that's worth us taking the time to think about, is autonomy. Right? We always talk about autonomy, but like, what exactly is it, and how would it relate to our transgender patient, to this person? So just so we're all on the same page when we're talking about this, when we talk about autonomy, autonomy is an agent, someone who has agency, who acts, someone who initiates their own action. You initiate what you decide to do. This sounds very basic, but it also has to do with authority to exercise your power to act, right? So you're an agent, meaning you get to act based on your own judgment and decisions. No one can make you do anything. If you're being forced to do something, you're physically being coerced to do something, for example, or tricked into doing something, your autonomy is being undermined because you're not initiating your own action, and you're actually not basing your action on your own judgments and your own decisions, right? So again, to act on other people's reasons or to be compelled to act undermines people's agency. And you can only initiate your power, you can only initiate your actions with your own power, right? So this is what goes into autonomy and what it means to be an agent. It means to have authority over yourself by the mere fact that you can initiate your own actions. So to have autonomy or authority over your actions, this is not based in a social or political role or any law or custom. So we're already getting at this idea that something about autonomy implies that this is cross-cultural. And I don't know if we have spent too much time thinking about this ourselves, but when we talk about our patients' autonomy, we are already subscribing to a moral theory. A moral theory that says to us that some things do not depend on culture, such as autonomy. Right? A person's authority over themselves does not depend on culture. And we'll come back to that. So again, a little bit more on agency and autonomy. Person has to regard their own judgment about how to act. That's what it means to act in an authoritative way, even if that judgment is that I'm going to follow what someone else tells me, right? So even if I listen to you, that doesn't undermine my agency so long as it's my choice or my decision to listen to you, right? Which again makes us susceptible or vulnerable, to manipulation, right? Our agency is always vulnerable to manipulation when we decide to trust other people. And this also made me think about the risk environments for transgender individuals. So risk environment, when we think about risk environments, we have to think about the harm that's caused by unhealthy behaviors as a product of social situations and environments in which individuals participate. So some of the health challenges that our transgender patients will bring to us, right, are environmental. And when I try to explain this, or when I imagine this is how I think about it. I was thinking about these pictures, these penguins, and everyone's like, oh, these penguins put a smile on their face, they look so cute, right? But then you have an oil spill. That's their environment. We end up with dirty penguins. So we might have people who come back, we might have our patients that come to us, dirty, quote unquote, if you will, from their environment. We can do all we can to clean them up, fix them up, but where are we sending them back to? Where are they going back? So how well do we know our transgender patients' environment? And when we look at this case and we think about transgender individuals in general, as in a healthcare setting, how is this person's autonomy being respected? Right? To be client-centered, I think someone in the chat said, ask about their gender identity or their pronouns, right? Like that would be a step to, if you will, give this person authority over how what's going to happen in the medical setting goes. I mean, medical settings are probably the place where for most people, regardless of gender identity, you know, your autonomy is undermined because you're relying on doctors, right? And how they treat you. So what policies and procedures at our own clinics, you know, undermine transgendered patients' autonomy? You know, and what can we do to support patient autonomy? So these are questions that I want to open up to the group about this case. Again, thinking about autonomy, transgender persons' autonomy, and you know, how we treat them, policies and procedures in our clinics that may enhance their autonomy or make it difficult for them to exercise, you know, their authority over their actions. You know, and what can we do to support them? I see that some.
Yeah, so this is Tabitha. Thank you. This is just such a really wonderful process. I just really want to thank you, Homero. I'd say just to support patient autonomy is advocating for real education in systems. I feel like just that without true training for like the system, clinics, wherever you are and whatever structure you're in, really just automatically puts the burden on the patient, and that we really have to start there. There just is not enough education for this population that is widespread, and certainly, you know, helping to turn back policy and implement real policy that is inclusive and is just, it's absolutely essential. So that would be my comments.
I also appreciate your thoughts on autonomy, Homero, because I think it did not cross my mind. And I think there's a lot of questions around autonomy, but on one end, it did not cross my mind at all to think about whether the transgendered person had refused, right, a pelvic exam in the past. That didn't cross my mind. So you're bringing that up, and whether there's something about this person's autonomy being respected could play a part into this. So I think having that piece of the history, and you know, in this case, but also as we engage with our transgender patients, to ask those questions. What is your preference? How would you like me to you know, if I don't know, actually, even as I'm saying this, because you see the negative, the outcome, the fact that the disease got much more severe. So I'm opening it to the larger conversation. What do folks think? Is it better that we approach everybody and say, you know, this is a complete physical exam. This is what I would do for all my patients, and have the person who's transgender opt out or ask the question, you know, do you have any concerns about me doing this exam? Or do we ask them first? Even as I'm grappling with all of this, I think this is really tricky for many of us that have not received the training, which goes back to really creating systematized curricular changes that are really sound and vetted by the transgender population.
And also understanding that there's a possibility that we as providers have caused problems with their autonomy by not wanting to do an exam on them, by avoiding it. So when you've gone to a number of providers who haven't offered that, and even if you ask and they said, no, we don't need to do that because of their personal biases, you know, what does that do to the patient with the next provider? And so I think, you know, that not only do we have to look at their autonomy from themselves, but based upon the history of relationship to other providers.
That's a very wise thought.
Anyone else? When I think of the environment, I think something very simple, and this is something that I've been trying to do myself recently. If it's possible, actually adding the pronouns that you prefer to use, not so much for yourself, right? But by doing so, you're signaling to the other person that you're aware that people use different pronouns, then that the pronouns they may prefer, may differ from, how they present, right? So, and I say this because, again, personally, when I first saw the pronoun stuff, it just seemed like, oh my God, that just seems like overkill, right? But then I realized, well, it's not for me. I'm cisgender. People are going to automatically use the pronouns that I prefer, right? It's so if I want to create an environment or signal to people who may be transgender or have a different gender identity that I'm open to, pronouns that they want to use, putting the parentheses in place after my name signals that. So maybe in your office, on your name badge, right? I think this is something very small, but I think can still be very powerful, right? Because you're signaling, what kind of conversations you're willing to entertain, you're open to entertaining, or what you understand about gender identity.
Could I add to that? This is Tabitha again. In just thinking about, again, something that may seem very small for some people, just going into a clinic or a hospital in that initial intake form where it's like, are you male or female? And it ends there. And not having, or even male, female, and other, like, it's just not enough, right? So if that is when you talk about policies and procedures, because then that's really system-wide versus how many of any given provider might choose to put the pronouns after the name, which is also an important indication that you have this safe provider that might be more open. But that really, it elevates it to that system-wide, a system-wide change that then invites more people just into the system right out of the gates.
Okay. Is anyone else? So I know we started a little bit after the hour. We're at the hour. There is one small piece that I would like to, whoever can stay or has a few more minutes, maybe another 10 minutes or so, that I wanted to run through. It's not a case, but I alluded to this when we were talking about it.
Yeah, we're happy to stay on, Homero, as long as you can and would like to. And for those of you who have to leave, feel free. We are recording the session and we'll make it available, but this is such a rich discussion and we'll stay as long as you'll give your time.
Sure. So let me just scoot down to where let's see if I can, oh yes, let me. Okay. So when we were talking about autonomy, right, I kind of hinted at this is supposed to be cross-cultural, right? You have autonomy in virtue of your capacity to initiate your own actions. This is something that you do. This is something that you have. Doesn't depend on the law. Doesn't depend on politics. Your autonomy is yours, if you will. But in saying that, right, you are implying that there is some kind of moral value, something of moral value that cuts across all cultures, right? Something that is universal, almost like a human right. Human rights are not supposed to be based on, do not depend on your culture. I have rights if I live in the United States, but if I move to China or Ecuador, I don't have human rights anymore. That's not how human rights work, at least not the concept of human rights or the concept of autonomy. But there are people who are relativists. So what is this? Ethical cultural relativism is a view that right and wrong depends on your culture. There are no absolutes or universal moral truths. Right? It all depends on your culture. So why would people why do they subscribe to these views? Some people think there's just too much moral disagreement and too much moral diversity. So there's just no way we can have a single, universal truth. Some people see even the idea of universal morality as Western imperialism. So they want to stop Western imperialism. There are people who argue. I've seen these arguments where people say the idea of human rights, for example, is a European construct from the age of the Enlightenment, right? By people who themselves didn't believe in the equality of all human beings. So who cares about human rights? That's very Western. Don't impose it on us here in China. We don't want to, we just don't buy into that. We're more Confucian. And people say, if we start buying into universal right and wrong, right, how are we going to tolerate people who have a different moral view, right? Are we going to like condemn people to hell? We think of, if you think about the, the conquest of the Americas, right? When religious leaders came over and felt like these indigenous people don't believe in Christ, and so they were like burned at the stake or mistreated, right? So we don't want that to happen, so we're going to move away from universal right and wrong. But I think there are problems with this, right? So I think people who do agree with, I see the appeal to cultural relativism, but I think the problem is you run into some very basic problems. So for example, you can't criticize slavery, right? All you can say if you really are a hardcore cultural relativist is that their culture believes in slavery, my culture doesn't believe in slavery, right? And if you think back on our own history, right? If someone was escaping the South, escaping enslavement in the South, right? You would be forced to say that they're doing something wrong because in that culture in the South, slavery is acceptable, right? I'm not a relativist, so I can criticize these practices, right? But if you are a relativist, you're kind of stuck with how do you explain away problems with slavery? If you're a relativist, you have to accept statues in honor of historical racist figures, right? There was a movement that started a few years ago with people going back and taking down statues, universities in England, right? They were taking down statues of famous racists, right? Who helped found the university or give money to the university here in the United States as well. And then, people would argue, though, this isn't fair, right? They had slaves, 200 years ago or 300 years ago. The times have changed, right? And I remember hearing that at NPR, people talking about, the times changed, times are different. And I remember thinking, have the times changed or have some people changed? Because if you ask Black folks today, if slavery is bad, they'll probably say yes. What about 50 years ago? I'm sure they would have told you the same thing. 100 years ago, they would have told you the same thing, right? So it's not like the times have changed, right? Because some folks have been telling you this is wrong all along, right? So if you're a cultural relativist, you have to kind of buy into these sort of historical relativist arguments. And you have to give up the idea of human rights. Right? Like, what do you say to someone who says, well, this is just a European construct? Well, if you really are a relativist, then you have to say, yes, that's true. So human rights applies to the West, but doesn't apply to the East. So again, the reason to this reason that there's too much moral disagreement or diversity, right? People who are against evolution, people who are for science, right? People who are anti-vaxxers, people who are pro-vaccines, right? There's still disagreement. There will always be disagreement, right? But the question is, disagreement is not an argument against moral absolutes. And a diversity of expression is not a difference in value. So just a very quick example. In Ecuador, putting your parent in a nursing home is like anathema. Like, why would you do that? You're like the worst son on the planet, worst daughter on the planet if you did that. In the United States, it's fairly common, right? Can we say that Americans love their kids less, their parents less? No. The love might be the same. How it's expressed is different, right? Perhaps putting them in a nursing home is the best thing I can do for my parent, or they can get care that there's no one in our home that can provide that care, right? So there's different moral considerations. So would we say that there's this fundamental moral difference between, Ecuadorians and people in the United States? I would say no, it's just expressed differently. Respect for parents is just being expressed differently. And this idea that we want to stop Western imperialism, I personally think it's a bunch of nonsense. We don't want this Western product. Well, you know what else is a Western product? Cars, very American. No one's complaining about cars, right? Coke, if you just look at this sign right here, this picture. I mean, there is Coke written out in Spanish, Japanese, Chinese, looks like Arabic, Thai, like all kinds of languages. No one's fighting Coke. Airplanes, very Western as well. Thank you, Wright brothers. No one's complaining about Western imperialism. I mean, really, what's Western? No one's complaining about this either, right? So the problem here is that there's a lot of ad hoc reasoning. People decide to kind of pick and choose what's Western and good to resist, and other stuff that's Western and it's okay, we like it because it tastes great. But what about adopting how we treat each other, right? Like the role of women in society, right? These are advances that some countries have made, like why not follow their lead, right? So, and more importantly, if you do oppose Western imperialism, that also depends on a moral absolute. You have to believe that there's something wrong about invading other people's cultures. Otherwise, you would just have to say, well, they believe invading cultures is fine, so I'm okay with it. And the need to tolerate differences. This is again, big reason why people want to be relativist, but I think it's a problem. Do we need to tolerate all differences, right? Here's a cultural group. Do we want to tolerate this? Right? Do we want to tolerate this kind of violence against women? So if you're a relativist, you would have no basis to criticize violent cultural practices, right? Because to criticize them, you would have to rely on a universal or some kind of absolute right or wrong. And you would have no way to differentiate between one cultural group or set of people who believe that Black Lives Matter and another group of people, right? If you're a hardcore cultural relativist, you would probably have to say they're both equal. They're just different cultures, just different beliefs. We can't adjudicate between the two views. Again, how do we differentiate between neo-Nazis and Black Lives Matter if you're a cultural relativist? So I just wanted to close. When we think about the cases that we looked at, some of these moral principles actually seem to perpetuate inequities, although they seem objective, right? We need to think about how they impact communities of color in particular. When we think about autonomy, the autonomy of our patients, especially for transgender individuals, like what does that mean? How do we facilitate that? How do we step on that, even if inadvertently? But also, if we are committed to autonomy, in a way, we are moving away from cultural relativism already. So all of this just points to our need to rethink our deliberative moral processes, especially when it comes to ventilators, because that may actually be a problem that we're going to start facing. Again, this is an opportunity for all of us to think and reflect. So just to review the objectives, the aim here was to get people to think critically about ethical theories that might be underpinning common moral reasoning, and to identify some of the limitations of cultural relativism. And that is the end of my talk.
Thank you so much, Homero. I've known Homero for a few decades, and we're friends and colleagues. And so thank you so much for being here with us. I'm going to ask Rachel if she would mind presenting her case. I think her case is extremely important because we're talking about racial and social issues associated with things that are happening right now with children of color in schools. So Rachel, can you take a couple of minutes and just present your case verbally?
Sure, I'd be happy to. Can you all see me okay? So
yes.
this is a patient of mine who I've known for probably 7 years. So she came in to see me. She's 40 years old. And she was extremely upset. Now, I have known her through her divorce a couple of years ago, but she came in to see me this year, and I didn't know why she was so upset. But her son, who's 6, sees the pediatrician in my office, and I know a lot about him too. I'm a family practice doc, so I've been following along with him because, as y'all know, if the children ain't happy, mama ain't happy, right? So I'm always asking about her son. And her sweet 6-year-old got an IEP. So I'm not sure if that's what it's called in other states, but in California, that's what happens in schools when children seem to have learning issues, which was appropriate that he have that because he has fairly significant ADD. And during that evaluation, this child had some issues as a toddler when mom and dad had a tumultuous end of relationship and then separation. He had some behavioral issues and he was a little rough with some children when he was a toddler. But he's now been working with our pediatrician, doing a whole new behavioral and nutrition program. No issues like that for 18 months, doing okay in school, except for that he's hyperactive and distracted. And she came to see me because during his IEP, his dad, he was under his father's care at that time, and his father just left him at the school by himself with the evaluator. And the son has a history of sort of trauma from being abandoned by his dad in different situations. And so he reacted during that specific interview with being really upset and having a big tantrum. And he came out of that IEP with a diagnosis of ADD, appropriate, I think, and conduct disorder, which is a heavy-duty diagnosis to give a 6-year-old child in any circumstance, but particularly in this one because it was particular. And she was upset because in the town I live in, we have about a 40% Latinx population, but we have a much smaller Asian and Black population. And he is a Black child in a primarily white Latinx classroom. And mom, who is Black as well, was very concerned about the impact of that diagnosis on his future. And so she said to this teacher who had evaluated him, please, can you remove that part of it? That seems like a very serious diagnosis for a small child. And she refused, and she said, well, can you please reevaluate him because it wasn't a normal situation. And the teacher refused, and she literally said to her, it's vital that the next teacher be informed that he might be a danger to other children so that they can look out for that in the classroom. And I heard the story and was pretty upset about it. So I'm really curious what any of you would think if this case came into your office. I assume we have some other healthcare providers on the line. And obviously you can
So, I will speak, this is Tabby. So with a child with an IEP, I would absolutely encourage this mother to get an advocate and fight the school system. And I mean, this is just blatant rights being shattered for this child and for the mother. And there are specific things that she could do to get advocacy and to support this process. And it is really unfortunate that you have one teacher making this type of determination, but there are real teams around this that if she utilizes that support, she would be able to get help with this. And unfortunately, having been through challenges with getting an IEP for, in our own lives, you really have to get help in the beginning. I believe a lot of parents can very easily get sidelined. Their children's needs can get sidelined. And I am so sorry that, just hearing this really, it's just not okay. So as a clinician, clinicians should really know that that there are a lot of resources. Sometimes you have to go outside of the system to get those resources, but really looking for the right advocate can help move these types of cases.
Yeah. And the pediatrician's evaluation is really important in this case, because this is a single assessment by one person, and this has the potential to follow this child through his entire life. So, you know, this is the critical moment where the mother needs, you know, support and advice and counsel and, you know, encouragement of her agency to advocate for her child. And so, you know, I think I'm hoping and believing that this can be turned around, but sometimes the school system protects itself, and it can be difficult to have these kinds of remarks and these kinds of thinking about children, particularly Black and brown children, removed. And sometimes it will take a fight, but the mother really has to advocate for this child because it's a tragic situation.
Yeah, the reevaluation is extremely important because it was situational, and the teacher, as Yvette was saying, trying to protect the school rather than trying to protect the child, because something like that can bias the next teacher to assume that something the child did that is very small is so severe that they will call, I don't know what school police are called, but they'll call the school police. And we've seen so many times where a little 5-year-old who threw a tantrum was handcuffed and taken to the police. And that just sets our children up to accept that that's their path in life. That, you know, whatever they do, they're going to be incarcerated. They're going to be handcuffed. And what kind of environmental bias are we placing on our children? You know, we were just talking about transgender and bias this environment. Look at the environment that we're placing these kids in by labeling them with that diagnosis. It's very unfair, and it surely shouldn't be done to a 6-year-old, by no means whatsoever.
So hi, I'm Rashid. I'm a pediatrician in San Jose. I think, Rachel, this poor kid and this poor mom really, you know, I was going to go for the last option, really needs the help of their pediatrician to advocate on his behalf. And also, since the parents are divorced, I think when they go for an IEP, the other parent has to sign saying, I allow, you know, the other parent, you know, the dad, to be the responsible party. But she can also argue that he left, and therefore they really do need to do the IEP again. You know, she can argue on the basis of use her divorce to her advantage.
Thank you, Rashida. I so appreciate that. And I was furious about this situation. And luckily, the pediatrician and I work hand in hand. We're very close. And so I talked to her, and she did, in fact, contact the teacher and contact the school. But I will follow up with her as to what happened, because this is how it starts. You know, you want to know how we target children of color. This is how it starts. And as healthcare providers, we have power here. You know, we are one of the voices they actually listen to. So I think it's really important to do it.
Yeah, we do. And it's so hard to get rid of a wrong diagnosis. I mean, literally, it's like almost impossible. Once you've labeled the child, it literally, it sticks with them throughout life. Or even if it's taken off the record, it's always there, you know, in the paperwork, you know, and it biases, you know, it'll follow him throughout to middle school and to high school as well if he stays within the school health, within the same school district. It's very sad.
And that external attitude that people have toward him because he had this label is in all likelihood will be internalized. And so even when that external pressure and that external negativity is gone, that internal voice and that internal knowledge will follow that person into likely not, you know, the best life. And we have data that shows that once these children are criminalized, they continue to be in the criminal justice system.
Exactly.
And Homero, I wanted to invite you. I saw you put up some slides for us specific to this, if you wanted to say anything about it.
I don't have too much to add. I do think that fighting the diagnosis is the way to go, and people have suggested that. I did put up the case in slides, if we had time to have gotten to it, but just to back up what some folks were saying, like I found this study of adolescents, male adolescents in juvenile detention, and like 70% had only been diagnosed, with conduct disorder. But when they were further assessed, they actually had other disorders, right, like depression or anxiety or PTSD. And 2/3 of them had, at least 2 conditions, right? So instead of being diagnosed properly, it's all being kind of funneled into conduct disorder. And the same thing happened to, for the girls. Same thing is happening there. Girls had even higher percentage, of having at least one other disorder. Yeah, I wasn't talking about bias, but you have all covered that already.
I would just add, you have the right to bring anyone with you that you wish to the IEP. And so even having the ability to bring your physician or your pediatrician, if that's something that, you would do on behalf of that child, when you have those meetings, you have the right to request a meeting. And, you as a clinician could attend that meeting if the parent wanted you to, as an outside voice, and document it. That is really important with the IEPs, is to document the process. And so those are just other tools to share with parents in these situations.
Okay.
Any last thoughts for just the whole session? Any comments or?
It was so wonderful, and just
There was
so-
one other comment that's in the chat. Can someone read that? It was talking about ADHD, and it's actually from a friend of mine who's a psychologist.
Would you be willing to read it? I'm trying to scroll through it and find it, Jean.
Yeah, I see it. The last comment, definitely having the child's physician, pediatrician who is outside the public health system is critical. You have the right to bring anyone. Oh, is that the last one? Ooh,
Yeah.
wait a minute. Is that one? Okay, you have the right.
There was something about ADHD. I'm looking for it.
Oh yeah, okay, yeah, no, I don't see that one. Yeah, I don't see that one.
It just flashed across my screen and now it's gone. Kiana, can you please unmute and say it?
Hi, can you hear me?
Yeah.
Yeah.
Hi, yes. So oftentimes, especially when diagnosing with children, depending on who's doing the diagnosing, we often try to go with a lesser diagnosis for all the reasons that you all just stated, because it does label the child. And a lot of times conduct disorder, later on, when that child becomes an adult, it's like this path that they're like this sociopath, which isn't true. A lot of times there's this misdiagnosis of conduct disorder and ADHD when really the presenting symptoms are anxiety. And so it's just unfortunate that, and then quite naturally medication comes into play for misdiagnosis.
Yep.
Absolutely. Thanks, Kiana.
You're welcome.
All right, so I am going to share my screen for a minute. And so first of all, I just want to again take a moment to just thank Homero del Pino. What a pleasure to have you come into our community and help us think around ethics and medical cases. It's just been such a robust conversation. We'd love to have you back sometime, Homero. So thank you again for taking the time today.
Thank you for having me, and this was fun.
Thanks, Amanda.
Thank you.
And just so you all know, we do these free webinars and meditations every week. Next week we'll be having a Monday meditation at 8:30 a.m. with Dr. Sandra Amato. So we welcome you. And then we will not meet next Friday due to the Thanksgiving vacation that many people will be on. So we'll see you the following week. But we do record all of our events, and please, you can go to our YouTube channel and find those afterwards. Think about becoming a member, joining the community, and we will see you all next Monday. So again, Homero, thank you again for your time. What a wonderful session. And for all of you who attended today, it's just lovely to see everyone. So
Thank you.
have a wonderful weekend.
Beautiful. Thank you, everybody.
Happy Thanksgiving.
Yeah.
Happy Thanksgiving.
Happy
Bye-bye.
Thanksgiving. Bye-bye.
Happy Thanksgiving.